Good afternoon. Everyone. Good afternoon or good morning, wherever you are located here in the nation. I'm going to go ahead and get started with this webinar. I want to thank you all for joining us this morning, afternoon, for our Indigenous How Topics / cancer conversation. This is a community discussion on colon cancer. This is our first collaboration with our cancer conversations that are held monthly as well within our Mayo Clinic Community Outreach Engagement program. My name is Corina Sabicu. I'm a senior program coordinator with Mayo Clinic here in Rochester, Minnesota, but I am Navajo and Jemez Pueblo from the Navajo Nation down in Shiprock, but I've been up in this area for quite a while. I'm grateful to be in this circle with you all to hold space for learning, healing, and connection. Today, we're going to share some knowledge to protect our relatives and empower our communities. So Mayo Clinic's Cancer Conversation series helps to bring some physicians, researchers, and community voices together to raise awareness about cancer, its signs and symptoms, treatment options, and supportive resources. We believe that education is a powerful medicine. These conversations help us recognize health risks, encourage screenings, and guide us to take care of our bodies with intention and respect. Before we begin, I'd like to take a quick moment here to just review a few housekeeping items. So at the end of this presentation, we will have time for Q&A. Please add all of your questions to the Zoom Q&A function that you'll see at the bottom of your screen. Let's strengthen our community. Please introduce yourself. I see a few of you already introducing yourself in the chat. Feel free to add your organization, role in the community, and also your tribal affiliation and location. It's always good to know where we have our community logging in from. All right. So next is just a quick, before we begin, I want to take a moment to complete a brief survey to share some knowledge about what you all know on colon cancer. So if you have a cell phone available, please feel free to scan the QR code on the screen, or also I will drop a link here in our chat. Let me see. I'm going to have to stop sharing really quick just to do that. Sorry, you all. Let's see. All right, so I'm going to drop the link in the chat. It's a really quick survey. If you could take the time, just a minute to take this, that would be great. Alrighty, there we go. And jump right back into sharing my screen. There's the survey again. All right. Okay, well, I'm going to go ahead and introduce Dr. John Molina, who is our guest speaker today. Really excited to have him. He spoke for Indigenous How Topics previously, I believe a couple years ago. He's also been a presenter down at the Mayo, Arizona campus. So we're always excited to have him join us and sharing his knowledge here. The topic today will be colon cancer in Native Americans. I'm going to go ahead and pass it over to Dr. Molina.
Okay, thank you very much, Corina, and I'm really honored to be here as I look at our audience who is coming just basically from all over the nation, all over the country, I really feel honored and really respect your time that you join us for this session. Again, my name is John Molina. Yosan Chamiavo, Amanetabote, Wahinewi, Tautem, John Molina. My mother is San Carlos Apache, and my father is Pascua Yaqui. And we live in the community of Guadalupe, Arizona, just south of Phoenix. As you can see, the screen behind me is basically our landscape, but that's actually during the spring when you see the poppies come up. But I just want to thank all of you for being here with us in this session. I would like to share some interesting and helpful information, hopefully, in colon cancer and its impact on our Indigenous communities. And we'll have some time towards the end to just maybe answer some questions, or maybe you all have some stories. At the end of my presentation, I'll share my story and my experience with colon cancer, and how I sort of became even more interested in this topic as a result of a personal experience. But anyway, with that said, let's go ahead and kick off our session, and please sit back, enjoy. And if you have any questions, you can just put them in the chat, and we'll make sure and come back and we'll kind of pick those up. So I'm going to go ahead and share my screen now. And this, I think, is going to work, hopefully. And I think you did, right, Corina?
Yep, we see ya.
Excellent. Well, today's July the 18th, Friday. Happy Friday to everybody. I am the director for the Arizona Advisory Council in Indian Healthcare here in Arizona, but I also lecture at the University of Arizona College of Public Health. And what I'd like to do, let's see here. Oh. Okay, let's see. Okay, good. All right. So just to give an overview, a lot of you may be familiar if you're in the healthcare field with colon cancer, and others maybe work in our communities, but I'd like to sort of give an overview of what we'll be talking about with regard to colon cancer, and then we'll be more specific talking among our Indigenous communities. We'll look at some risk factors, some symptoms, how it's diagnosed, treatments, how we can look at colon cancer from a preventative point of view, and the impact of colon cancer among our Native American people, Indigenous communities. So what is colon cancer? Well, basically cancer, it's a cancer of the colon or rectum. And if you look at the lower right-hand side, you can see the intestines there. We have the, what's called the, excuse me, the ascending colon. We have the transverse colon. We have the rectum, the sigmoid colon, and the small bowel. In general, when we talk about colon cancer, we're basically talking about the ascending, descending rectum, and the sigmoid colon. That's where we tend to find most of the cancers. And most of these cancers start as non-cancerous growth. They're called polyps. Now, in that little circle, you can see kind of a lesion inside the intestine. That's actually a pictorial graph of what a colon cancer would actually look like. But again, they really start off as polyps. You might think of them as small skin tags inside the intestine. And when we find these polyps before they become cancer, they can actually keep the cancer from developing or spreading. And just to say, and this is probably one of the takeaways from today's slides and presentation, is the recommended screening age is actually 45. It's come down over the last couple of decades, only because now we're finding colon cancer rates are becoming more common among younger people. So as I mentioned earlier, the polyps are little abnormal growths in the colon or rectum that may grow out of control and become cancerous. There on the left-hand side, we see what we can picture as small little colon polyps, the little outpouchings that are inside the colon, and they grow in the lining of the colon or rectum. Now, on the right-hand side, I thought I'd just put what these polyps can become. On the right-hand side, these polyps can grow and change in its form and actually become cancer. And typically, when we look at cancer, for these polyps that go out of control and become cancerous, they're usually staged. You know, they from small to big. They can be stage 0, then become stage 1, stage 2 cancer, stage 3, and stage 4. And as you can see, the bigger the cancer gets inside the colon, the 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 larger number of staging that it becomes. Then, of course, even though the cancer may be located inside the colon, as you can see, these cancer uh, lesions are tied into the lymph nodes. And when they're tied into lymph nodes, like it shows in this picture, that's where the small cancer cells can start to spread into other parts outside the intestine and potentially to other parts of the body. So what are the risk factors for colon cancer? Well, you know, when we talk now about any kind of risk factor for any cancer, we always talk about genetics. But actually, for colon cancer, probably maybe only 5 to 10% of cancers are related to your genetics. So it's a very small portion that genetics plays in the development of cancer. The other is family history. You know, having a close relative, blood relative that may have had a colon cancer puts you at higher risk, probably higher than genetics. Obesity is also a risk factor. Race is a risk factor. We find that colon cancer is usually found in cultural ethnic groups like African Americans, indigenous people, Hispanic people, usually darker skinned people. We tend to see cancer more often. Then the other potential risk is what's called IBD, or inflammatory bowel disease. This is another intestinal type of condition where there's a lot of inflammation that goes on inside the bowel, causes a lot of bowel symptoms like pain, bouts of diarrhea, constipation. And then type 2 diabetes is another risk factor. And so I guess we can, when we think about risk factors, sometimes there could be more than one risk factor that's associated with the individual. In that case, the more risk factors you have, then probably the higher risk that person has of getting cancer, or potentially take for instance, they're indigenous, they've got type 2 diabetes, they're a little on the heavy side, and maybe they have an aunt or an uncle that had colon cancer, then that puts that individual at a pretty high risk for colon cancer. So what are the symptoms for colon cancer? Well, as I'll show my story a little bit later, polyps and early cancer may have no symptoms whatsoever. You know, and this is the thing that I think is another sort of a takeaway point, is that cancer doesn't always have symptoms. Some of the symptoms that a person may experience is change in bowel movements, you know, maybe going between diarrhea and constipation. Also, there could be a change in the color of the fecal matter. It will start looking dark, almost black, and that's a result of blood that's coming from inside the intestine that's changing the color of the stool. There's gas, bloating, nausea, vomiting, abdominal discomfort, as far as the local symptoms. But also in general, maybe there could be a loss of appetite, fatigue, weight loss. And, you know, and those systemic symptoms that we tend to find, fatigue, weight loss, and loss of appetite, is typically related to potentially the cancer have already spread to other parts of the body. And because those same symptoms are found in other kinds of cancer when it's gone a little bit further spread. And again, to say not all patients are going to have colon cancer symptoms. So the take-home point here is that it's important that early detection be the direction that a person goes before any symptoms arise. And that's why, you know, the recommended screening age of 45 is something that to always keep in mind for men and women, because at that point, it could be found a lot earlier on, even before any symptoms might arise. So in the diagnosis of colon cancer, you usually the best and probably the gold standard is having a sample of the polyp or a sample of whatever lesion is in the bowel. And the sample is usually done during a colonoscopy. But usually some of the diagnosis of cancer is, first of all, a complete physical examination with laboratory work, blood work. Usually the doctor will also do what's called a digital rectal exam, where an exam is done through the rectum to feel if there's any type of a tumor or a mass inside the sigmoid and rectal area. Colonoscopy is usually the gold standard to see inside the bowel. And this is usually by inserting a sigmoid into the rectum. And as you can see on the right-hand side, this scope can go all the way through the descending colon to the transverse colon. And it's got a light at the end of it, so the provider doctor can actually look inside and look for any polyps or growth that might be in there. Of course, biopsy of any polyp or lesion in the bowel will help see if there's any cancer cells. Also CBCs, any kind of blood work that can be done to try to bring that diagnosis a little bit closer to what's happening. And then all liver function tests are usually done also because a complete sort of laboratory work helps to also say potentially the cancer may have spread to other parts of the body. Sometimes, depending on the individual, a surgery may be needed to get the tissue sample, but in most cases, a colonoscopy works really well for that. Myself, I've had probably since my 50s, I've had 3 colonoscopies, and I can tell you that they're pretty benign. I think one of the things among our indigenous people is we might feel uncomfortable because of the type of procedure and how it's done. But quite honestly, even for those of you that may have had it and you might want to share your story, because I think one of the things of our indigenous people is they're concerned about getting a colonoscopy. Our people are very private, and this is an area that maybe might seem uncomfortable to some people. So if you have a story about your colonoscopy, maybe you can share it at the end of the presentation. But it's really pretty benign. You go in and you talk to the doctor, and they sedate you, start an IV, and they put you to a nice, comfortable sleep. And it seems like you just sleep for a few minutes. You wake up in the recovery room, and it's all been done. And so pretty straightforward and pretty safe, and it's really the best way to identify any potential things going on. Now, there are other screening tests other than the colonoscopy to see if potentially there could be something going on inside the intestines, type of cancer, early cancer. And these are usually stool tests. You have to take a sample of the stool, because what happens often is the polyp or the potential cancer inside the intestine might have a little bit of bleeding, and having that little bit of bleeding will be captured in the stool. So they do have these stool tests to check for tiny amounts of blood in the feces or the stool. So being able to test for that blood in the stool is critically important, because if they do find blood in the stool, then that takes it to the next level to say, now we perhaps need to do a colonoscopy. Because just having blood in the stool doesn't mean you have cancer, but it takes it to the next level to say, well, now we need to go in and see what happens. So, but if there is no blood in the stool, then that's a way of saying, well, it looks like everything's okay. So again, this is not the gold standard. Again, colonoscopy is a way to go, but these are tests to just screen. I guess it's better said that it could be a screening measure to see if there is cancer. And they've got all these sort of interesting words. They've got the G-phobit, they got the FIT, and they got the FIT DNA. And those are just, they're different types of tests, but essentially they're testing stools. And These stool tests usually have you take the kit home, and then you get the sample at home, after you have a bowel movement, and then you take it back to the clinic, or you can, in my case, the way I've done it, if I've actually put it back in the box and you can mail it to like UPS, and then it goes where it needs to go. But the first one, the G-FOBET, is a guaiac fecal occult blood test. And as you can see, that's that slide that some of you may have seen, where you have a little card. You scrape off a sample of your stool, you put it on the right little slide, then you put a testing solution, you close it up, and you take it back to the clinic so where it can be tested. Then you have the FIT, fecal immunochemical test, also known as IFOBIT, and that's immunochemical, basically the same thing, except in this case, you also still need to get the sample and you put it on the little device there that's a immunochemical test, and it'll show either positive or negative for blood. Almost like a pregnancy test nowadays, you can actually say if it's positive or negative for blood, and obviously pregnancy testing is positive or negative pregnancy. They've really been able to develop a lot of nice tools for screening. And again, sometimes our people may not feel comfortable with this because, again, it's a very private thing for some of our people, especially our elders. And this is something where I think we as providers, or if you work in the community, would be great to sit down with our people and just explain it and help them feel comfortable with it. And I think once we start talking to them about it and kind of making it a little sort of light, they would be able to maybe feel comfortable to do that with a little bit of instruction and support. Then, of course, the other one is the FIT DNA, also referred to as a DNA test, and it sort of combines some of these other tests. But what that looks for, it looks for DNA. It looks for DNA that's not normal, and this DNA is usually coming from either the polyp or the cancer. And again, that's another way to see. So just keep in mind that these are only screening tests. It's not the actual testing for cancer, but it does provide a sense of insight on whether you could be that there could be nothing happening in terms of any type of potential cancers or polyps. But on the other hand, if it does come back positive, it could be the time to maybe then take it to the next level to say, okay, maybe we now need to do a colonoscopy. So treatments for colon cancer, and again, the thing that we find out in healthcare is that basically it in most cases the treatment for colon cancer is just to remove it, but there's other treatments that have been used because again surgery can be a little bit more riskier. So they've come up with other types of treatments. And again, the treatment depends on where the cancer is, how big the cancer is, the type of cancer, and the physical condition of the person. So there's a lot of factors that go into the treatment for colon cancer now to make it a lot safer for the patient. And this is something that the patient and or the family, especially if it's an elder, could talk to the providers, the physicians, the surgeons, to look at the best type of outcome in cancer treatment for the individual. So again, for colon cancer, treatment depends on the size, the location, and potentially how far the cancer has spread. Down on the right-hand side in the photos, surgery is obviously one of the things that is still done. There they have to actually open up the abdomen, go in. They have to open up the intestine to remove the cancer. And many times they have to have a bag afterwards, a drain. So surgery can get pretty complicated and a little bit riskier. And especially maybe the patient may have other comorbidities. Maybe they have diabetes, respiratory issues. Maybe they're more obese. So these are some of the conditions that make it riskier. We just go to point out that being able to get screening ahead of time could potentially avert any type of surgical intervention. The other one is ablation therapy. It's being done more common now. I have a friend that's an interventional radiologist, and he works a lot with surgeons. And basically, ablation therapy is being able to use a needle, I guess, kind of a simple way to put it, use a needle, and you go in directly, through the skin to the cancer that, and you can either heat or freeze the cancer itself in bulk. So in essence, you're freezing or you're heating with heat that cancer and will destroy the cancer cells, and then obviously the tumor will then self-destruct. Uh, Radiation therapy is another type of treatment for colon cancer, and that's usually done when it's not a good idea to do surgery, or perhaps the cancer has spread a little bit outside the intestine, so there's a wider area that needs to be treated. So radiation therapy might be something like that. Again, this is something that takes time from the patient. They have to go in so many times a week, or maybe 3 to 6 weeks to get therapy, radiation therapy, to be able to treat the cancer. And of course, there's always chemotherapy. And again, chemotherapy in many cases is done in conjunction with surgery. Sometimes after surgery case, it finds out that maybe it would help to add on chemo after surgery or ablation therapy. Chemotherapy is usually done if there's been some spread outside of the intestine, much like we saw in that one photograph where we see the cancers actually going through the lymph nodes and going out into other parts of the body. Then there's targeted therapy. Again, with new technologies coming up in medicine, we find that certain drugs are being developed when they can actually go to the actual cancer cell itself when infused IV. They're like little robots that go into the bloodstream and go directly. They're sort of attracted to the cancer, and they go towards the cancer and able to destroy some of those cancer cells. And of course, immunotherapy is just another way to also to be able to provide certain kind of type of antibodies, like antibodies to be able to attack the cancer cells. So these are all the different types of treatments that are available. And again, a lot of it depends on the size of the tumor, where it's located, how far the cancer has spread. Now, again, just to kind of clarify that these cancers are usually found in the transverse and the descending colon and the rectosigmoid area, usually the last part of the large intestine. Don't usually find them in the small intestines. And just to mention that surgery is a primary treatment and for cancer, colon cancer, and it has a high cure rate. About 50% of patients can get cured by the surgery. Now, keep in mind that it has to be localized to the bowel, and this is where you get the best cure. If the cancer is still in the bowel and hasn't spread anywhere else, then surgery can really be the best form of treatment to take care of the cancer. Well, we talked a little bit earlier that there's a lot of factors that go into putting a person at high risk for colon cancer. We talked about being overweight, obese. We talked about diabetes as another risk factor, probably that. And so there's certain lifestyles that I think are important to consider in preventing colon cancer. And again, we'll see a little bit later in this presentation how our Indian people have been impacted by colon cancer as a third leading cause of death. So first of all, the thing is to just get regular screenings. When you go in to see a provider, the provider usually has a sense, depending on your age, what screenings that you may need. We're all trained in that type of approach. It's called prevention. And we know, given your gender, your age, what's next up for your screening to prevent cancer in general. Like, for instance, for women, for mammographies, for pap smears. For men, it's prostate screening, colon cancer screening. Because this is a good way to make sure, because we get busy in our lives, we're doing things, we forget things, we just keep moving, and because you feel okay, you think, well, I really don't need to go in, but I always think of it as a car. You you buy a nice car, you get a brand new car, you're driving it, nothing's happening, the lights aren't coming on, and you keep driving it, you know. But then we forget that perhaps we need to rotate and balance tires. We need to maybe get the oil changed. We need to maybe do preventative maintenance to make sure the brakes aren't wearing off. But many times, because we're so busy, we just let it go until something gives or you hear something. Then it's telling us that something's wrong when it could have been prevented. So the same thing with our bodies and our own physical condition is, and like myself, after I got my colonoscopy, um, I started getting my annual screening. So every year, um, I go in for my annual screening, and it's usually around the springtime. I kind of keep it in mind that, okay, it's time to go back to see the doctor. And yeah, sure enough, what always happens is you go in to find something else, but that's okay. I mean, you want to take care of yourself. But then again, you want to make it a point to pick a time during the year that you think would be a good time to make sure you go in for an annual screening to get checked for everything. The other thing is eating healthy. Now, I was in a conference last week, and one of the things that we find among our indigenous people is before colonization, before we were moved out of our traditional lands, we had lands where we harvested, where we hunted, drank the water. Everything was pure, everything was good. Everything was low fat, high protein, non-toxic. Our indigenous people before colonization had a very healthy life. Well, unfortunately, after colonization, our people were then made to depend on the government for reservations. And of course, it took care of us with food, but unfortunately, the commodity food is not the best food. You add on to that with modernization, stores, and preservatives, and it's not a very good, healthy food environment outside of us anymore. You know, especially for our people, our tribal people who still depend on the commodity foods, which is okay. I mean, we need to eat. So what I tell folks is, first of all, one of the things our Indian people have always believed is that food is sacred. Food is sacred, you know. And the thing among our, like with our desert people, picking fruit from our desert plants, Alaskan relatives, the salmon, San Carlos, the acorns, poppies is corn, so we have certain foods that we've always seen as being sacred. And I think that same kind of thinking is good, even though we don't have access to our traditional foods or don't have as much access to traditional foods. And I know some of our tribal communities are working towards getting more indigenous foods to serve our communities. But for us who live in the urban areas, we may not have that opportunity for indigenous type foods. What I would say is that think of it in moderation. Uh, think that the food that you're going to eat, whether it's store bought or you had to unfreeze it, think of it as sacred. Take a moment to thank Creator that He's given you this food for your body, and that you only take as much as you need. You know, I know for myself, sometimes I get into these binges, but I have to remember, my father who's passed away at the age of 92. I'll kind of make this comment to me one time when I was young. He said, son, your your stomach is only as big as your fist. Well, guess what? When I went to medical school, I say, wow, when I'm doing anatomy, you're right. Your stomach's not very big. So why do we need all that food? You know? So I always try to think about it in terms of just how much you need, not how much you want. I okay, my wife and I love going to buffets. Okay. Whether it's a fish buffet, it's a Chinese food buffet, it's a Mexican buffet. And boy, I got to tell you, the way they put out the spread just makes you want to eat it all. But we have to be a little bit mindful at that time. Just take what we think we need and make it variety. Make it as much variety as you can. A little bit of meat, a little bit of maybe carbohydrates, vegetables, kind of like it shows on that photo. Just a little bit of everything that you need. And on top of that, water. Again, my father, my father never went to high school. He was a migrant farmer or farm labor. but he had this kind of advice that our elders gave us that totally makes a lot of sense. He said if people ate like they drink water and drink water like they ate, they would be a lot healthier. He told me that years ago. And I find that, everything in moderation is good. Everything that our creator gives us is good. And unfortunately, the world has sort of put a little bit more toxins in food, but our body can take care of it. Just we take what we eat, what we need. We try to diversify it in all the different food groups, and we take it down with water. That's what the only advice I can give in the modern world that we live in. Be great to be back in the days where our ancestors, where we hunted, and we fished, and we harvested, and we gathered plants. But those days are pretty much gone. So we try to do the best we can. The other thing, stay physically active. Now that doesn't mean trying to run a marathon or become a weightlifter. Basically, just moving a little bit more. I know it's hot nowadays, but being able to get outside early in the morning or later in the evening. In fact, these days, this week have been kind of nice. To just get out and walk a little bit, being active, do a little bit of strengthening exercises if you have that. Again, talk to your doctor about how far you can go and being able to do exercise. But for me, it's just getting up and moving. When I go to Walmart, I usually try to park a little bit further away so I can walk a little bit, make that walk. I know a lot of us are now doing DoorDash and all this kind of stuff to bring food in, but maybe a trip to the store once in a while, it's not going to hurt because you get out to walk. You're walking a little bit. Walking is great, and sometimes I'll even take a little bit more time at Walmart to walk through all the aisles to get my exercise in a little bit. In the meantime, I might find something that I really need. Maybe so, but just getting up and walking, just moving is probably great to do and kind of helpful. Avoid drinking and smoking. That's very, very good. Smoking is not good for us. A lot of carcinogens in cigarettes. I know through ceremonies, we do have ceremonial tobacco that we use for ceremony. That's a little bit different. A lot of the ceremonial tobacco is natural, comes from the bark of trees, and that's good. It's used under ceremony, prayer, and that really is a way to make us balance in mind, body, and spirit. Drinking alcohol is it's not good, especially in large amounts. I know people like having a little bit of wine. My grandmother would have a little glass of wine every night before she went to bed. Some people advocate for a little bit of red wine to be helpful. Again, it's in moderation. And then the other thing, know your family history. I know when you go to the doctor, they'll always ask you, did you have any parents, anybody that they had cancers and things of that nature. And maybe sometimes we need to talk to our elders, talk to auntie, talk to uncle, talk to grandma. Hey, did anybody in our family have this or that? And it's always good to know, to have that family history that you can talk with a provider with. Okay, well, just some statistics to talk about colon cancer and our indigenous people. There's a study that was done back in 2012, 2016 that looked at cancer rates in the North Plains, Alaska, Southern Plains, East Coast, and the Southwest. And what they found is that, of course, our native people there in those places studied were more likely to get colorectal cancer than white people in those regions. And I think that's always been the case, and something that we just mentioned early on. The other thing is that native men are more likely to get colorectal cancer. That's what CRC stands for, colorectal cancer. And again, the colorectal cancer is where most cancers happen. In that little diagram that we show, the descending large colon that comes down, and then it sort of makes a little S and comes out and becomes the rectum. That part between the large colon and then towards becoming the rectum is where most cancers are found. And that's why the doctor will sometimes examine a person in that area. But it shows that the other thing that's been kind of difficult in understanding cancer rates among Native people, and some of us have who work in data and epidemiology have found that many times our Native people are miscategorized as another race, or maybe they might even put us as Hispanic, and not being able to get correctly classified, it kind of disturbs the data that providers are trying to get a handle on, or people who work with data and epidemiology. And our cancer data is spread everywhere. You know, it can be with Indian Health Service, can be with the tribe, can be with CDC, can be with ADHS. And one of the things that we work on a lot in Arizona is trying to get more handle on this data, because it's important to our people, important to providers, healthcare organizations, to get better ideas of these cancer rates so we can better address it. And then, because again, like I said, these cancer rates, you usually what we do in cancer rates in Indian country, we tend to get it from the Indian Health Service, the database, and also from purchase and referred care, because obviously our people who do need to have some kind of intervention for cancer end up being referred out. So you usually purchase and referred care is used unless they have insurance. And of course, purchase and referred care also capture the information, but that's another way to be able to track some of these cancer rates. So, because again, understanding cancer rates in your community is important, because it helps you to sort of develop policy and strategies to improve maybe screening rates, or how you can improve screening rates. And I think that this really is even more important, you know, in our 638 facilities and those programs where tribal communities run their cancer prevention programs. This data is very helpful because they're able to strategize and really able to fit the cancer type of prevention and screening that they need for their people. Another thing here, in Alaska, 2018, they had the highest rates of documented colorectal cancer incidence in the world up in Alaska. And again, you know, when you think of all the potential risk factors, when people take a look at data like this, they really take a look at all the different types of potential risk factors and how and why that happens. And again, it's good to know, because then you can develop public health strategies to try to address those factors that might be causing that. And again, it's not well understood yet. I think that's still under study. But they think they might be related to factors like tobacco use, physical inactivities. You know, our relatives up in Alaska feel kind of live in remote, icy areas, so maybe physical inactivity might be low fruit and vegetable intake and alcohol consumption. So those are some of the potential factors that could be with our people up in Alaska. The other thing I wanted to add on to this, and I'm going to keep track of time here a little bit so we can have some questions and answers at the end, is they found that Heliobacter pylori may be associated with colorectal cancer. So what is Heliobacter pylori? It's a little bacteria that resides in your stomach and cause ulcers. People may have it and not even know it. It can usually cause the stomach to make more acid and can lead to stomach cancer. Can be passed from person to person, such as kissing or having contact with vomit or stool. Can be passed on with food that's not cleaned or cooked in a safe way, or drinking water that's infected with Heliobacter pylori. Some of the symptoms, dull pain that doesn't go away, happens 2 or 3 hours after you eat, dull pain in the middle of the night when your stomach's empty. Pain goes away when you eat or take medicines like antacids, not feeling hungry, losing weight, swelling, bloating, burping, having upset stomach, nausea, vomiting. If you have these kind of symptoms, it's probably good to get checked for that in the stomach, because even though it's a potential cause for stomach cancer, they've also associated Heliobacter with colon cancer. And of course, the usual workup includes blood tests and stool culture testing. Again, going back to the stool, they even do breath testing, able to check to see if there's any carbon in your breath that you swallow a little pill. And then upper endoscopy, that's a gold standard. Just like they go from the other way for colon cancer, they can come the other way for the potential stomach cancer, or looking for Heliobacter pylori. Treatment for Heliobacter includes antibiotics, very common ones: amoxicillin, clarithromycin, metronidazole, Pepcid, Tagamet, Axid, other things like Prilosec, Prevacid, Nexium, and stomach lines. Pepto-Bismol, an over-the-counter, was also used in treatment of he hit Heliobacter pylori. Okay, well, let's kind of summarize things a little bit here. So just to summarize, we find that 1 in 23 men and 1 in 25 women will develop colon cancer in their lifetime. And colon cancer is the second leading cause of death for Native people. Second leading cause of death. And that's kind of concerning because the other thing is, as we went through this whole presentation, colon cancer is preventable in the majority of cases through screening and prevention. It does not have to be the second leading cause of death for Native people. The screening age is 45 to 75 or sooner. Is if you have a family history, you found out that auntie and uncle, grandma, grandpa had colon cancer, you might want to get sooner screening. And again, screening tests that you can get, depending on how often annually. And of course, other screening tests is colonoscopy. Right now, it's recommended every 3 to 10 years, depending if they found polyps or not. And again, this is something that you can discuss with the provider and talk about colon cancer screening. Get comfortable with it. Get comfortable with it, because again, we do want to lower that cause of death for Native people. So again, this is just things that we've talked about. It's preventable and treatable. We a healthy lifestyle. I know a lot of tribal communities have a lot of wellness programs that are going on, and that's amazing that we're doing that. Take part in them. Take part in your wellness program. Get to know the people there. A lot of walking paths have been developed in some of these programs, and make it fun. Make it for the whole family. Teach your children, because then they too will take on those prevention type activities. And within our tribal programs, look at your policies and interventions that can support an increase in colon colorectal cancer screening. Chirkoy, thank you. This just want to close with this. That's your little granddaughter up in Albuquerque, the Gathering of Nations. And one of the things that I think is important for us to recognize as adults is that we're not only doing this for ourselves, but we're doing that for our children, our grandchildren, next generations. Because like this little girl, I mean, she likes her papa. She likes being around me all the time. So grandpas, dads, grandmas, mothers, we want to be as healthy as we can for our children and our grandchildren. We want to see them graduate from high school, go to college, or wherever, or whatever they do. If they want to become a rapper, that's great. We just want to be there for them. So as Chief said, Papa La Puta, let us put our minds together to see where we can build for our children. And I'm going to close with my quick story and then get some time for any questions or answers about my experience with colon cancer. 2005, it was about 20 years ago. 20 years ago, I had an uncle who died of colon cancer. And we were very close. And when they diagnosed him at a late stage. They did the surgery. He did chemotherapy. And he passed away 4 months later. It didn't work as well. But while he was in hospice at home, I asked him, I said, Uncle, did you have any symptoms? Like, I mean, this was pretty far out. I mean, he already had this big tumor and spread, and they did surgery, they did chemo, and it didn't work. And I said, what, no symptoms. He says, no symptoms whatsoever. I felt fine, I felt good. And then one day I just started having this pain in my stomach. I went to see the doctor finally, and they found out I had this big cancer tumor. And that's why they decided to do something, and it didn't work, at least not for treatment. I said, oh my gosh, no symptoms whatsoever. I mean, you're talking to a doctor here. Thank you. I appreciate that now. And I go, okay, well, I should know better. I mean, I should know as being a provider that I need to get screened. At that time, I was almost 55. My uncle passed. I said, you know what? Maybe I better go get checked. Colonoscopy. So I went to see the doctor who recommended, you just need to get your colonoscopy. You passed your date. So I did. And guess what? They found 4 cancerous tumors, polyps. So they took them out right away, got them taken care of. As a result, I needed to go back and get an colonoscopy earlier, three years later, and then 5 years, and then now every 5 years, and now once. I guess my next one is due in 2 years. So if it wasn't for my uncle passing and sharing his story, I wonder, gee, what would have happened? So anyway, so I'll just stop there, and yeah, he saved my life, And I just want to stop here now and thank you all for your time, and see, Corina, if we want to take it to our participants if they have any stories or questions.
Yeah, for
Thank
sure.
you.
Thank you, Dr. Molina, for sharing your family story there. Sorry for your loss as well. But it just stresses the importance of our screenings for this specific cancer. I really did enjoy the analogy you gave about keeping up the maintenance of your car. So thinking of it in a similar way, we have to keep up with those maintenance in order to keep our cars running. So it's the same way with our bodies ourselves. So that was really awesome analogy you brought up earlier, but we do have some questions to get to. So I'm going to jump into those questions here. The first one, I might not be too great at pronouncing this, but it says, can this, speaking of colon cancer, can this also be from diverticulitis?
Yeah, absolutely. Great question. Thank you. Yeah, because diverticulitis can also cause inflammation in the stomach and intestinal lining. And anytime you have inflammation, whether it's the intestines, whether it's in the breast, or it's in the stomach, inflammation can cause cell changes. And this inflammation is these cell changes in that area of the body, like the intestine, can then affect the DNA of that cell and cause it to become cancerous. Diverticulitis, especially when you're having symptoms, there's always a source of inflammation that could potentially do it. So, yeah, great question. Thank you.
All right, another question. What changes in bowel movements should one note are signs to get checked?
Well, typically, the first change is the color of the stool. Again, what happens with polyps or potential cancers in the intestine might have a little bit of bleeding. When that bleeding, as you know, most stool, and I hate to get too gross here, but most stool can either be light brown, can be gray. You kind of know what your stool looks like. But when it's black, unless you've taken some kind of medication or food coloring, because the blood mixes with the stool, the blood causes the stool to turn black. And I'm saying black, like this shirt, black like this shirt. That's one sign that there could be some potential bleeding. Again, if you haven't taken any kind of medication or food coloring or something. The other thing that they've talked about is constipation, because that tumor cancer is in the bowel, and you're having to push harder to get it around that tumor. So you're pushing harder. And then the other thing that we learned in medical school is your tool might be stringy. That means because the cancer is there and it's trying to push through, it comes out a little stringy. Now, those are like pretty obvious, changes. And I think if everybody kind of has an idea of your normal stool pattern. So if you notice any changes in your stool pattern that just doesn't go away after 2 or 3 days, you might want to get checked out, But again, other than that, you might not have any symptoms. You might have a little bloating, upset stomach, a little bit of pain that doesn't go away. So, but those are some of the signs that would say there's something really going on.
Okay, thank you. May have covered this next question, but is there a new procedure available that is not as invasive as colonoscopy, but almost just as effective to identify issues?
Well, yeah, there is. There's a technology where you follow where you swallow a photo pill, a pill. You swallow it. It's got a camera in it, and you swallow it. It goes through your stomach, your small intestine, and it goes through your bowel. And while it's going through your bowel, it's taking pictures, you know, it's taking pictures, kind of like a little drone inside your intestine. It's taking pictures. And then once you pass it in the stool, you take it back and they're able to replicate the photos and they're able to see if there's anything in there. Now, the only problem with that, it doesn't capture everything. As you can think about it, it's tumbling around in there. So it may not capture everything. Colonoscopy is the best way. And I know, some people might feel uncomfortable with it, but it's better because it's a guided colonoscopy. If the physician is actually able to kind of look through all the bowel, it's kind of like what the plumbers use. If you ever have had a plumber come to your house because your sewage has backed up, they use a scope to go in and they can look at all around the surroundings. And not only that, if they see something, they actually put a little instrument in there and they're able to take a bite of that little polyp and bring it out. So then that goes to the lab and they're able to see. So a colonoscopy is able to see everything. They can go all the way up, the descending colon, up the transverse colon, maybe even down. And then if they see anything, they'll take a little biopsy of it and they'll take it out. So, and again, like I said, it's not even painful. I mean, it's like going into a really light sleep. You wake up, yeah, it's a bit drowsy, sleep for a little bit, but you don't feel any pain afterwards. You don't even know it happened. And it's probably the best way. But other than that little camel pill, I think that's only one that I can think of. Yeah, good question.
Thank you for that. Next one is, what are your thoughts regarding young people? So under the age of 45, who may not have hereditary risk factors, but may be concerned about colon cancer risk due to their race, poor diet, and obesity. Would you recommend they buy the stool test?
Yeah, first of all, I would probably recommend that, and I really have to give credit to these young people who are thinking that way, because that shows that this kind of education will get to our younger people. Because there was a time when we used to think about type 2 diabetes, we used to call it adult onset diabetes. Now our little kids are getting diabetes at the age of 11, 12, and 13. So I think when we're talking about colon cancer, even though we say 45, I think that kids who are thinking that way, or parents who think about kids, is really a good way to think about prevention. Now, in that case, I would probably recommend that that the young person go see the physician or the pediatrician and let them take a look at everything, their diet, their living habits, their weight, their risk factors, and then see what the provider might think. Now, depending on what the provider thinks, they might decide to do one of those screening tests, the stool screening test. And every clinic has a different type of screening test. We showed, I think, 4 of them, or 3 or 4 of them, and the clinic might have one or the other. So while they're there, they'll be able to pick up that test at the clinic, and then the provider, the nurse, will show them how to do it. That's probably the first step, just to make sure there's not any blood in the stool. And that way, if there's no blood coming out, then we're probably okay to say, oh, I think you're okay. And then maybe repeat it again in another few months or another year. So it kind of all depends, but that would be my thoughts on that.
Next question, how can plant-based
Thank you so much.
lifestyles be helpful in management or prevention of colon cancer risk?
What was it again? I'm sorry.
How can plant-based lifestyle be helpful in management prevention of colon cancer risk?
What kind of based lifestyle?
Plant-based.
Okay, gotcha. Okay, plant. No, absolutely. I think one of the things that a plant-based lifestyle brings is that it allows the stool to move through. I mean, obviously, that's one of the first things we think about. And for me, the way I think about it is the more you can get stool moving through, the better. It doesn't hang out there. You drink water, you eat plants. The other thing that I really believe, and this is my own personal opinion, is plants are medicine. You know, especially if they're grown in non-toxic areas. But plants have a lot of qualities of reducing inflammation, you know. And sometimes if you do research on the on plants, or if you're a vegetarian, you'll find that a lot of these plants have anti-cancer properties. So I would really recommend, high plant use, specifically if you live on a tribal community. Maybe there's certain indigenous plants that their ancestors used, they planted, they harvested. Certainly, if you go to the store, anything that has a color to it, it's green, it's yellow, it's orange, it's red, it's good. Because all of those plants, vegetables, fruits have anti-inflammatory and anti-cancer types of ingredients that would be very helpful. Now, meat is also important to have. I think having a meat-based diet is good. The best we can do sometimes is low-fat meat, portion sizing. We do need protein also, so maybe a little bit of that. But I know there's other choices that you can get protein in. That's not meat-based. That's another thing to think about. But again, I would probably advise that if you have, questions about diet, nutrition, some of the tribal clinics, facilities, they have dietitians and nutritionists that can help with that, especially in the area that you live in the environment that you live in. So, yeah, thank you. Good question.
All right, we have a few more questions. I know we're past the hour, but I'm going to go ahead and get to the questions for those who are still around. Okay. Does the FIT DNA test only detect when polyps advance to cancer? Is it a replacement for colonoscopy?
Okay. The FIT DNA is not a replacement for colonoscopy. But what it does, these screening tests, and what it checks for the DNA is for the DNA for any potential polyp, because a polyp has changed its DNA structure from a regular stomach lining cell. So it'll pick that up. It'll also pick up any DNA that looks like it could be potentially cancerous. So the screening tests are really only a screening test. Now, if it's positive, it means that you could potentially have some polyp activity going on, or maybe a precancerous polyp. It's telling you that, but you don't really know until you get the biopsy. And the only way to get the biopsy is through a colonoscopy. I remember back when I was doing my surgery rotation, the quote was, no meat, no treat. In other words, if you don't get any biopsy, you cannot be treated. You need the biopsy to treat it if you have it. Now, on the other hand, if the DNA, thank you, Archie, great have you here. If the DNA, if FIT DNA comes back negative, in other words, it shows nothing there, then you're probably okay. Then you can say, okay, it looks good. Maybe I'll do it in another 6 months, or do it in another year. Again, something you can talk to your provider about. But it's only telling you basically if you need to get a colonoscopy, or you can perhaps wait if it comes back negative. So,
All right, thank you. Last three questions. So one of them is, what is the best ways to make an impact in increasing colon screening for Indigenous people?
the best way is to sit and talk with them, because every individual will have a different perspective. Maybe they had a bad experience. Maybe they heard something on social media. Maybe they had a relative. The best way is to sit down with that person and find out why. Why is it that you think you don't want to get a colonoscopy? And I think when you get that information, it helps you navigate. It helps you kind of lead the discussion, lead the narrative on that. The other thing I find is that some of our people may not be comfortable talking about it, but like with anything in life, the more you talk about it, the more comfortable you'll feel about it. Because sometimes in our families, they used to say, well, we don't talk about that. We don't say things like that. But when it comes down to our health and your wellness, having that one-on-one conversation with them, either through the provider, through the nurse, through the medical assistant, through the CHR, and just sitting down with them and talking it through. is really, really a best way to get to them and to see what it is that sort of guides your way of thinking on that and make them comfortable with the conversation, you know.
Okay. What has been most successful way to encourage our patients to undergo screening? We have not been very successful for our community.
Yeah, another great question. Well, the first line is where we have our providers talk to patients in the exam room. I remember a study years ago that kind of said that, like with smoking, when a provider talks to a patient to say you should stop smoking, 20% of patients will take that advice and stop smoking. But that's only 20%. So you do get 1 out of 5 to stop smoking. When I had my clinic in Guadalupe, one of the things that I found very helpful was to have community people come together. Back at that time, we were doing a lot of work in diabetes screening, diabetes prevention. So every Thursday evening, our clinic would put on a small meal, a small kind of a meal, because, food brings us together. And we would get people to come together and have a meal with us and have each other talk about their experience, what they knew, what they didn't know, what their fears, what there was, especially around colon cancer. If you can get a group of people to come together and, do a little bit of a feed, maybe give away a little bit of raffle, have them come together and just talk to each other. Talk to each other and maybe have a provider guide the conversation, not tell people, but let the people do the instruction towards each other. I found that to be very effective because how people share their stories in that environment can sort of impact other people. And again, it makes them feel comfortable with the conversation. And when you get these small groups together, I think it really enhances the exchange of knowledge, maybe the courage to want to do it and understanding of it. But it's sort of people self-teaching each other and encouraging. And it's not always the provider doing it. That's what I found effective when we did this type of approach with diabetes.
Thank you. Last question we have here. One thing I have run into are our patients that have to be hospitalized for their prep due to fragility or mobility issues. Any thoughts?
Yeah, there's the thing with colon cancer is we found out it tends to impact mostly older individuals. And among our indigenous communities, when some of our elders get into the 50s, 60s, and going to the 70s, they do carry a lot of other physical concerns with them. Could be musculoskeletal, could be weight, could be diabetes, could be respiratory issues, could be rheumatism, could be all sorts of things that makes it a little bit more difficult for them, for the doctors to perform any kind of treatment or surgery. So they do have to come in to sort of get prepped up, if you will, to try. We used to say it in medicine to tune them up a little bit so they can be a little bit more fit for the procedure. In those cases, I think, our elders are kind of concerned about even having to go through all that. I've had elders to say, it's fine. I don't need this. If I go, I go, I guess in some ways we have to respect that, our elders. But on the other hand, family is always important. I've always seen families come together and encourage our elders, to come and get those, procedures done or whatever in the hospital. But again, the elders don't like to be alone or isolated, especially in hospitals, being in a hospital room. So if they do have to go, I would encourage, for the kids, the grandkids, come and see them, bring them things while they're there, make their stay as comfortable as you can, maybe having a medicine person come in, spend some time with them. That support is so important. Family support is critical, especially you have to go down that route. I wouldn't leave them, just alone in there. I would always have people coming in, bringing in things, praying over them during ceremony. I think that's would be good.
One last question that was just thrown in the chat that I think is important. What if you lose your state medical benefits to have a colonoscopy screening and have no insurance to do so?
Well, that's going to be a potential issue coming up once we get through this Medicaid changes. The only thing that I can advocate for, if potentially there might be some IHS facilities or 638 facilities that do, I mean, for a person that's enrolled, that has benefits through an ITU, Indian House for Tribal Urban Clinic, that potentially there still will be some facilities available where they can do the colonoscopy. I know that there's some 638 facilities that do colonoscopies, and if the person didn't have any insurance, that might be a resource, because then obviously there's no copay because it's being done at a tribal 638 facility under the Indian Health Service. So that would be my only option. But that's an interesting question, and I'll take it back to our advisory team with the state, because maybe what we might want to do going forward is identify certain IHS 638 facilities that do perform colonoscopies, because they're the person, if they're a member of a federally recognized tribe, might be able to get the service if they lose their Medicaid benefits. Good question.
All right. Thank you so much, Dr. Molina. Thank you for this wonderful conversation on a very important topic on colon cancer. I want to thank you again for presenting today. We're always happy to have you as part of our conversations with our Mayo Clinic team here. So thank you. I just want to leave you with last thoughts, Dr. Molina.
Well, again, my last thoughts is, Creator gave us a wonderful life, a wonderful body, and I think life itself is a gift. And I think if we look at it as a gift, we'll take care of ourselves as much as possible. I know some of us do have some physical, concerns. We have some physical disabilities, but it's still life, And in a way of thinking, when we think about mind, body, spirit, and community, we think about the medicine field. We as Indigenous people have the advantage of looking at life as balance. We use spiritual activities, use community support. We use as many things as we can to keep us as healthy as we can. And it's all about keeping healthy in our mind and the spirit that kind of gives us this vitality for life that helps us go through anything. And the last thing is we take care of ourselves as much as we can for next generations, because we do want to see our children grow and see our next generations. And I just appreciate all of you. I'll appreciate all of you for being here. So Chioko, Ahia, thank you.
Yeah, thank you all. We'll see you next time.